and working towards attainment of the TB strategy goals for the country. So this afternoon, he's going to take us through TB orientation on TB, the disease, TB prevention, the risk factors, the diagnosis, prevention, and control. And I would like to take this opportunity to thank the AMREF team, including Christine with your team. Thank you for your support and also arranging for this webinar. We will have 40 minutes of presentation, and then we are going to have time for question and answer. So please have your question and answers ready, and also you can type in the question, and please tell us where you're listening from and who you are. Thank you very much, and welcome, Mr. Karoli.
Thank you very much, Dorcas. Maybe you can confirm if you are hearing me from your end.
Yes, go ahead,
Yes,
please. I can hear you.
So thank you once again.
Can give a thumbs up. Thumbs up if you can hear the team.
Thank you, colleagues who have joined this webinar. As Dorcas has mentioned, this is part of the pre-World TB Day engagements or build-up activities where we want to engage our stakeholders as we strengthen our efforts to end TB in Kenya. My name is Karoli Migwambo. I'm the County TB and Leprosy Coordinator for Homa Bay. So this afternoon, we are having this opening webinar, and we had invited our colleagues, the community actors, our colleagues from any other workplace, institutions of higher learning, and any other stakeholder from the community who is key in helping us to achieve our end TB goals. So it'll allow me to take you through the discussions. If you have any comment, you can type on the chat box. And I think once I'm done, we can have a short plenary to address your concerns. So it'll allow me to move my slides. That is the outline of our presentation, just to give you a brief introduction of tuberculosis in Kenya, how TB presents among those who are affected, risk factors for tuberculosis, how we make diagnosis of TB, and then the treatment protocols we have in the country, how we support our people who are affected or who have TB disease, and finally, how we prevent TB from affecting our people. So tuberculosis, as you know, is a disease that is caused by a microorganism called Mycobacterium tuberculosis. We have several species, but let me be specific to the one causing TB, which is called Mycobacterium tuberculosis. TB has remained a very important disease of public health because it is one of the leading infectious killer diseases in the world. According to the recent statistics, it is estimated that about 1.7 million people globally are infected with tuberculosis. So right from the onset, we need to understand that there is TB infection and TB disease. So about 1.7, almost a third of the world population is infected with the TB. But not all those who are infected will develop the disease. It is, from statistics, about 5 to 15%, on average 10% of the people who are infected could progress to active disease. So according to the data, it is known that about 5% could develop TB immediately within a few years, 2 to 5 years. The remaining 5 who have got strong immunity could have TB in their bodies, but when the immunity goes down, then they progress to active disease, what we call secondary TB. But the good thing is that tuberculosis is preventable, it is treatable, and people can be cured fully, and they get back to their daily Some background on the burden of tuberculosis. The country did a very elaborate prevalence survey in 2016, and some of these findings actually informed our renewed commitment and strategic directions in controlling TB. So there are 4 key findings from this prevalence survey. One, The results of this survey told us that the burden of TB in Kenya is actually higher than what we had been reporting. We are told that in every 100,000 people, about 426 actually have got TB disease. The other thing is that we are missing some cases. We are reporting roughly 60% of our estimated cases of our incidents. So about 40% of our cases are still missed. And this is a very good opportunity for us to engage as stakeholders, especially colleagues from the community, because we believe the missed cases are either in the community or somewhere in institutions or even. So once we know the basics about TB, how to recognize TB symptoms, I think we can mop up the 40% so that we can achieve the end TB goals by the year 2030. The second thing that came from the prevalence survey is that TB tend to affect more males than females, and this is evident from our data. We also learned that TB mostly affects people in the urban, especially the peri-urban dwellings, where we have a lot of overcrowding. Then, as opposed to what we used to know that TB mainly affects the HIV positive, but the prevalence survey told us that we still get a lot of TB, 83% from the HIV negative population. And finally, we also saw that in the old age, more females tend to be affected more than males. The third finding that we got survey finding that we have been doing screening using symptoms alone, where we ask patients about the key symptoms of TB, cough, fever, weight loss, blah, blah. That when we combine chest X-ray as a tool for screening, then we will pick more people who can be helped when we finally take sample to the lab and we diagnose this. Again, we also saw that our traditional method of diagnosis tend to have limited sensitivity, but when we use the current molecular diagnostic methods, that is GeneXpert and TrueNut, we tend to get more TB cases, and that is disease, we treat them, then we stop transmission. And then lastly, on health-seeking behavior, we also realized from the report that we have people in the community who experience these symptoms, but traditionally they tend to take them as just minor symptoms. That is my cough, my fever. They don't think TB. So we have people in the community who have symptoms, but they're not seeking care. They think it is just the usual symptoms in the community. We also saw that people, when they become sick, some may not go to the health, instead go to the nearby clinics where they first of all seek care. The survey told us that a quarter of those who were found to have TB actually did not present with any symptoms. And that's why chest X-ray is very, very critical, because those who have subclinical disease, when we do chest X-ray, we are able to pick the abnormalities, they give us sputum, and we are able to diagnose TB. So the question we've been asking, where are these 40% that are missed from our incidents or from our estimates? One, as I said, is that some people, these people are in the community, but because the symptoms they exhibit to them seem to be non-severe, then they don't want to, or they are not going to the facility to seek care. Secondly, we still have people at work, and it is good we are meeting this constituency today, people at work, people in school, learning institutions, people in clinics. The presumption is that they may not have TB, but we know that TB can affect any community, any individual. So we call upon people at all levels, any constituency, be it workplace, be it school, be it at home, that if you experience any of the symptoms, you go to the nearest facility for early diagnosis. And finally, those who are seeking care, sometimes they tend to be missed depending on the systems or the flow of patients in various facilities. So with that background, I have the honors to refresh ourselves or remind us on the basics of tuberculosis, so that as community actors, as stakeholders, we know what TB is, how do we control TB in our community. So TB, the word TB stands for tuberculosis. As you are aware, I said the organism causing TB is called Mycobacterium tuberculosis. So it tends to affect the lungs. Actually, more than 80% of cases actually affecting the lungs. But it can affect any part of the body. And we know there are structures that are not richly supplied by oxygenated blood, like the teeth, the hair, and the nails. So those structures are not really affected by tuberculosis. And then we'll see when somebody has got TB, when they cough, they discharge some droplets into the air, and this is what usually make transmission to TB very possible. We really need to give a lot of information to our people to ensure that the houses where we live in, they are well ventilated, because this bacteria, if it is exposed to sunlight, then it may not survive. So when we have good ventilation, it's a way of killing the bacteria, not to infect people. But if you don't do that, sometimes if there's no good ventilation, TB can remain suspended in any closed environment for many hours. And then if we don't protect tuberculosis, we don't protect our people from this bacteria by providing adequate sunlight, it can remain suspended for many weeks. We know that tuberculosis in the lab, it can be seen using the microscope, and it is usually a rod-shaped bacteria. It survives where there is oxygen, and that is why lung, because that is where we have oxygen being processed. Most of the cases actually affecting the lungs. So this is how the bacteria looks like, a rod-shaped bacilli. It is spread when somebody with the disease, when they cough, sneeze, or sing, to some extent when they laugh or talk. But the first two are the main mode of TB transmission. If somebody has got active TB, when they cough, then they tend to discharge the bacilli from the lungs through their mouth or nose. Especially sneezing tends to discharge a lot of bacteria into the environment. So when a person in close contact with this infected individual breathes in the bacteria, then they tend, first of all, to go into the lungs where there is good oxygenated blood. So it affects the lungs, but it can also be spread to other parts of the body. So any TB outside the lung is called extrapulmonary TB, while TB with affecting the lungs is called pulmonary tuberculosis. So just to take you briefly through the cycle of tuberculosis, that when an individual is infected, you can see the lungs here that are affected with tuberculosis. Then they become source of infection. So when they cough, they discharge the droplets into the air. They can remain suspended for hours, especially in enclosures in environments that are not well ventilated. So when a close contact breathes in the contaminated air, they also get infected and the cycle continues. So we really need to address this. Those who have got active disease, we put them on treatment. While those who are infected, like here, we can even cut the process before it gets to active disease. We'll mention the issue of TB preventive therapy. We can stop this dormant TB from becoming active disease. So when somebody gets infected with the TB and has got active disease, in adults, this is how they present. People will present with a cough. Sometimes that cough can come out with blood, what in other terms we call hemoptysis. People tend to sweat a lot at night, and they present with what we call a drenching night sweat. They can experience chest pain, difficulty in breathing, persistent fever, fatigue, and unexplained weight loss, mainly for adults. While in children, cough still is a common symptom. They present with low-grade fever, and adolescent or older children can also experience night sweats. Children will tend to present with poor weight gain. So if they go to the clinic, the MCH, and the weights are being monitored, they're not gaining weight, and as expected, some will present with stunted growth. Children usually play, but when they have TB, they become very weak, what we call lethargy, and even their level of playing will also reduce. They present as well with difficulty in breathing, And when we are looking for TB or screening children for TB, it is important to ask for history, ask the caregiver if somebody had got been treated with the TB in the household. So we'll ask the caregiver, the mother, the father, or any other caregiver, whether this child has been exposed to somebody with a chronic cough or somebody who was treated for tuberculosis. So graphically, those are the symptoms that I've mentioned: fever, cough, weight loss, night sweat, chest pain, coughing of blood, and as with any other disease, people who have chronic illnesses or even acute illness, they will present with the lack of appetite. So as I mentioned, we have two types of tuberculosis: pulmonary, which is in the lungs, and then extrapulmonary. I said TB can affect any part of the body except the three structures that I mentioned: the hair, the nails, and the teeth. So a few cases of extrapulmonary, you can see on the extreme top left how this child presents with TB of the spine, how it appears a bit twisted. On the top right, swelling on the neck, same to the bottom left. And then on the bottom right, a child who is not able to walk. Sometimes they present with paralysis, sometimes with swollen abdomen. So basically, TB can affect any part of the body. So there are some of the risk factors for tuberculosis. And risk factors are those that factors that contribute to infection. They can contribute to transmission and even development of active disease. So first of all is malnutrition. As much as TB itself can cause malnutrition, but if a person has got malnutrition actually presents with lowered immunity. So if they get infected, they can easily progress to active disease, what we are calling primary tuberculosis. Chronic diseases like diabetes, people who are on long-term therapy, using drugs for a long time, like cancer drugs, drugs like steroids for a long time. Then extreme ages, especially the very young, those who are aged less than 5 years, and the very old, people aged 65 years and above, they have lowered immunity, so they cannot mount that immune response to contain tuberculosis or the bacteria in the lungs. HIV infection, and we are aware TB is among the commonest opportunistic infections affecting HIV-infected individuals. Poor ventilation and natural lighting, unhygienic cough, overcrowding and poverty, socio-economic status, occupation like those who are exposed to silica, other also that emit a lot of biofuel or smoke. It can compromise the lungs, and it predisposes individuals to getting infection and disease. Then chronic alcoholism and smoking similarly can affect immunity, and you end up getting infection and disease. So anybody can get TB, but those who are likely to progress to active disease, I told you that infection is that stage where you get the bacilli in the system, but because your immunity is strong, it will be contained for some time. But if you don't have strong immunity, like this category of people, I said children, especially those aged less than 5 years, those who are malnourished, elderly people, people with diabetes, people with HIV, AIDS, people who live in overcrowded places, they can easily get tuberculosis infection and progress to active disease. So for diagnosis, it is important that we recognize those symptoms that I mentioned above. So we advise that whether you are in the community, at the household, whether you are at the workplace, institutions of higher learning, congregate settings like prison, companies, it is important to recognize the symptoms that I mentioned so that when you go to the hospital, then the clinician or the doctor will have easy time to get your history that would be pointing to tuberculosis. So one of the most important history we get is the history of contact. If a patient comes with a cough, weight loss, and then there's history of contact, it is easier for us to think in the direction of tuberculosis. But whether there is contact or not, the clinician needs to evaluate all the symptoms. And then the next thing is to do examination on the patient and even do more on the chest because that's where the lungs are. But I say TB can affect any part of the body. So depending on the presentation of the patient, the doctor or the clinician or the nurse will be able to do those systemic examinations on our patients. Once they evaluate the patient and they meet the criteria of being a presumptive TB case, then we take sample for testing. And our preferred test here is the molecular test because the DNA PCR, which is highly sensitive. And apart from being sensitive, the gene expert and tuner test is able to tell us whether the TB we're dealing with is already resistant to a key drug called rifampicin. We still have our traditional method of diagnosis called smear microscopy. We have come up with another technique called TB lamp. We also have another test targeting mainly people living with HIV called LF lamp, where we use urine to test for TB. We can also get other samples like biopsy from our patients, depending on the site of the body that is affected. So the samples that we use include, mainly we take sputum, but you can also take stool for under 5 years. We can do gastric aspiration for children, especially those who are less than 5 years and are not able to expectorate quality sputum. We can take cerebrospinal fluid. This is a sample we take from the spinal area of the patient. We can also take pus, depending on the area that is affected. Radiological examination will include X-ray. We've done X-ray, especially now we have the digital X-ray that is AI-enabled. X-ray with artificial intelligence, which is able to not only give us the picture, but also able to interpret for us and even give us the scores. Then we can do CT scan, MRI, or ultrasound as a supportive method for screening, and also can confirm TB, especially now for children. So these are some of the equipments that we currently use. I told you that Gene Expert is one of the preferred tests because of the sensitivity and even ability to detect whether there is resistance at the onset. On the right is our traditional method called microscopy. And the reason we are commemorating World TB Day is that this day, 24th of March, the year 1882, is when our renowned physician called Dr. Robert Cox identified TB in sputum. And he announced to the world that we have gotten a breakthrough because now we are able to confirm the cause for these chronic symptoms, because patients were being managed supportively. They will be taken to sanatoriums. There was no cure for TB. But when it was confirmed in the lab on 24th of March, then that was a breakthrough for us in TB control. So smear collection is very important. So any patient who has got the symptoms I mentioned above, and the doctor has done examination and confirmed that this is a presumptive TB case, then we really need to educate our patients, because quality of sputum really is very, very important. And at the bottom, you can see the container we use routinely to collect sputum sample called Falcon tube. So we give them this container. We explain to them how to give us quality sputum. So we need to have cough zones. But if a cough zone is not available in the facility, then we have a designated open area. We advise our patient to wash their mouth with water to remove any food particles that could affect the quality of the results. Then they need to take deep breath 2-3 times. Then they'll cough out deeply and give us quality sputum. So when that is done, they close and then they take it to the laboratory. And with the technology that we have, the PCR technology, the molecular test, turnaround time has been very good. If you are in a Gene Expert facility, within 2 hours, the results should be out. But if you are not in a Gene Expert facility, the samples will be taken, will not be sent to walk or travel long distance to the Gene Expert site. But the program and the government has come up with very robust system called sample networking. So they will collect sample at that peripheral facility, then they take to the Gene Expert site. Then within 2 days or 3, we will be called just to get your results and take back to the doctor for decision making. So treatment of TB, currently we have very effective treatment regimen. And our treatment for TB will be based on the weight of the patient. So once we diagnose TB, we'll have to do the baseline vitals. The most important one is the weight, because the number of tablets we'll give you depends on your weight. So we have weight bands and the number of tablets to give to our patient. So we really want to emphasize on adherence. We usually give a lot of health education, counseling, and support our clients for the time they are taking their medication. So we really want to call upon all stakeholders that we want to support our people who are on treatment, because they live with us in our household, so that we avoid treatment interruption. The risk of interrupting treatment is that the disease can worsen and have very, very bad outcomes. Secondly, the patient may develop drug resistance, which is more expensive to treat. So for adults, we treat for 6 months. So we have got 2 phases of treatment. We have the intensive phase that takes the first 2 months, and then continuation phase takes the next 4 months. So during the intensive phase of 2 months, we give a combination of 3 or 4 drugs combined together, what we are calling fixed dose combination. Not that we take separate tablets and combine, but these drugs are already combined in the tablet. So we give you the dosage depending on your weight. So the first 2 months, they are taking a combination of drugs, 4 drugs combined together. So the number of tablets will depend on your weight. Then for the continuation phase of 2 months, continuation phase of 4 months, they will be taking only 2 drugs. And during the treatment, because we confirm TB in the lab, we have to do what we call smear follow-ups to check whether the drugs are working. So we do clinical follow-up and bacteriological follow-up, which is very key. So at the end of 2 months, we repeat smear microscopy to check whether the bacteria has been cleared from the system. We repeat the same at the end of 5th month, and then the third follow-up is done at the end of 6th month. So basically, we are treating people for 6 months, but there are cases where we can extend the continuation phase to 10 months. So that treatment period goes for 12 months or 1 year. And these are patients with very severe forms of TB, including TB meningitis and the TB of the bone. For children, they also take treatment for 6 months, but because of very robust research we've done and guided by WHO, we have come up with a shorter regimen for 4 months. So we categorize our children as those who are having non-severe TB and those who have severe TB. So those who have got non-severe, we can treat them for 4 months. So 2 months of intensive and another 2 months for continuation. So that is the criteria between 1 to 10 years. If they are stable, they can be put on 4-month regimen. Those who are HIV negative, those who do not have severe malnutrition, and finally, those who do not have any other comorbidity. Otherwise, the rest who have got what we call severe disease, either they are HIV positive, those we have confirmed in the lab, and then those who have got severe malnutrition and any other form of comorbidity or immunosuppression, they will continue with the standard 6-month regimen. And then finally, the 12-month regimen also applies here for children if they have TB meningitis or TB of the bones. So while patients are on treatment, we continue to monitor them. We give them clinic appointment to come. As much as we monitor progress, we also check for what we call side effects. So side effects are what has not been expected from the medication, but there are also those that are expected, though are normal, like when you're treating a patient for TB, some of the issues we need to tell them that these drugs may cause some of the unfamiliar presentations, like their urine might change. That is expected. But when these effects become severe or they are affecting treatment, then we need to monitor and address them. So during the treatment, it can occur, side effects can occur at any time. So we advise the caregivers, treatment supporters to help us observe this. So the household, they need to help us implement what we call DOT, directly observed treatment. So when they realize any unusual presentation, they need to remind the patient to come back to the facility. Some of the minor side effects include effects on the digestive system. Like with any other drug, a patient can complain of nausea or vomiting or diarrhea. So we really need to encourage them to take fluids and not to stop and just continue with treatment as we monitor. Some could present with itchiness of the skin, red urine, which I said due to rifampicin. All those presentations, we need to review them at the facility. Either we reassure or we manage appropriately. Some of the side effects could be severe and affecting treatment, like when a patient presents with yellowness or discoloration of the eye and other mucous membranes, it could be a pointer to liver injury effect on the liver. Some could present with poor vision or they're not able to appreciate any color. That could be due to another drug called ethambutol. Some could present with shortness of breath. Also, some drug like isoniazid can cause what we call peripheral neuropathy. So patient will present with the tingling sensation, they feel some pain on their feet, so they need to come back to the facility so that we see. But usually we give a drug that prevents this kind of neuropathy called pyridoxine. So our call to action is that the community actors and stakeholders from the community, you need to help us so that the patients adhere to treatment. Okay. So the reason why adherence is very important is that when you are on medication, you're not likely to transmit the disease. And then if you take your drugs well, chances of getting another episode is very minimal. And we also want people to be cured because that's the only way we can stop TB transmission. So if you adhere well, we'll repeat a smear follow-up at month 2, 5, and 6. And we are likely to declare you cured because the drugs have killed the bacteria. It also cost effective because if we treat you for the first time and you're cured, you adhered well, then we don't expect episodes, we don't expect any drug resistance. So it is important for us to save us from buying more medication. It also gives us good outcomes. So the best or the desired outcomes from treatment is either you are cured or you complete treatment. So we don't expect other undesired outcomes like mortality. So if you are there well, then you will be presenting or getting good outcomes, and you are not likely to develop resistance to the anti-TBs. But on the flip side, if our patients do not adhere well to treatment, they are likely to complicate with their drug resistance, which is more expensive to treat. And then there's likelihood of recurrence of TB. The cost of treatment will go up because we are treating you for a second time, or you complicate with the drug-resistant TB, then it is more costly. It will increase transmission because if you don't destroy the bacteria in the system, when you cough, you still discharge the droplets containing the bacteria. It will affect either the household contacts or the community, so you can transmit if you don't adhere well. Then you can present with treatment failure because the drugs are not working optimally expected. We also want to avoid poor outcomes like mortality. So for our colleagues from the community, we really want us to work together so that we support DOTs in the household. So DOTs can be supported either by the household member, the caregiver, or even the healthcare worker. We also have the community health promoters in the households, on the community, on the villages, so they can also help us. But we start with household members because they are with the patient on a daily basis, just to help us observe or remind our patients to be taking their drugs as required. So we want to involve the relatives or the treatment supporters to help us promote adherence by giving psychosocial support, physical support to the patients, because this treatment takes a long time, 4, 6, or 12 months. So they really need a lot of support from the household members. We continue to give health education to our colleagues to know that TB is curable. So once you start treatment, you don't stop. And then we'll also try to give IC materials to the households or to the patients when they come to the facility so that they can have facts about TB and how it is controlled. Community actors, again, we need to remind our patients that we'll be doing a smear follow-up test just to check whether the drugs are working at month 2, month 5, and month 6. So this is the information we give them at the baseline, at the start of treatment, especially those whose sputum were confirmed positive in the lab. At the end of month 2, we repeat month 5, and finally month 6. So we really need to support our patients, but should they experience any other complications or any other side effects, severe side effects, we really need to refer them to the facility. We'll continue to update our records and also offer counseling and adherence support to our patients. So finally, the call to action here is that we really need to work together so that we can achieve the end TB targets by 2030. So whether we are from the household, the learning institutions, and other places like the workplace, we really need to talk to our colleagues about TB, how it is prevented. But those who present with symptoms like cough, if we can facilitate their referral to the nearest facility, the better. I know there are institutions like workplaces, companies, or even higher learning institutions, they have their medical clinics. So they need to work with the clinic staff if they have any of the symptoms to be evaluated. If they do not have diagnostic facility, they can network sample. Or if the institution does not have any medical facility, then we need to refer any individual with the symptoms to the nearest facility. We want to support our people, those who are diagnosed with the disease, to be treated early enough. So if you diagnose early, then the outcome of treatment will be better, whether they have drug-susceptible TB or drug-resistant TB. We want to continue offering DOTS, directly observed therapy, and also adherence support. I also mentioned that there is TB infection and TB disease. So those who have TB infection and are high risk of progressing to active disease, like the contacts of the bacteriologically confirmed TB, like the people living with HIV, like our prisoners, like our healthcare workers, colleagues, healthcare workers, because of the nature of our work, we are taking a short course of preventive therapy called TPT. We have got a very friendly formulation that is taken on a weekly basis for 3 months and is able to kill the dormant tuberculosis in our lungs so that we stop the process of advancing or progressing to active disease. And we also encourage that our children are given full immunization. You know, our first immunization and birth includes BCG, which is very, very key in TB prevention. And finally, at all levels, whether the workplace, at the household, or the facility, we implement what we call TB infection prevention and control, IPC. Thank you very much. Our theme for this year, remind ourselves that this is what is driving this year's World TB Day commemoration. Yes, we can end TB, led by the government and powered by communities. Thank you very much. Allow me to stop there and take it back to the moderator.
Thank you very much, Mr. Karoli. We should give him a virtual claps. We thank you very much. Just to summarize, I think we have been through what TB is. That is a bacteriological disease spread by a droplet. It is preventable and treatable, and it is curable. And actually, our role is to ensure that we facilitate prevention of TB in the community, facilitate early diagnosis through awareness and also referral of patients, support each other and other patients to form adherence of treatment and care, and also remind them and support them for follow-up of sputum, and to reduce all this, to reduce patient costs in TB management and also improve patient outcomes during the treatment and care, and also for the loved ones and people who have been in contact with these patients. So I think also, in addition to that, when we are made aware of TB, we become champions of TB. We become safe agents. We can require people who have symptoms of TB, encourage them and require them to be tested, and also to become agents for other people who have TB and other TB related risks, and also advocate for TPT, and also for financing and integration of TB in all the community settings and county level, even at education level, where we have people who are in training institutions. You can advocate for measures to ensure that there is prevention and of TB. And also, if there's any contact that you are able to go to seek care from healthcare workers. So, as you said, we are working towards World TB Day, and it is guided by the government but powered by the community. And the community is all of us, that we have been able to be empowered by Mr. Karoli's presentation to be able to power the advocacy for TB prevention and control in Kenya. Without much ado, I would like to go to the question and answer session. Mr. Karoli, I hope you've drunk a little water. So I will start with one question by one Stephen Anguva. Sorry. No, yes. How are counties engaging TB champions to improve uptake of TPT? And if there's any experience from best performing counties? So maybe we can start with that question before we go to the other questions. Mr. Karoli, please.
Thank you, Steve, for bringing out this. I'll give you an experience from Homa Bay County, where we have a network of TB champions, and they have their chair. I don't know if he's in the call, known by the name David Taro. So we have been working with our SRs on a quarterly basis to have a meeting with our TB champions, and we give this basic information, including TPT.
Mr. Karoli, please remember we have new people listening. So when you use abbreviation, please try to explain what that means.
Thank you, Derkas. I was just trying to make an emphasis on what Steve has brought out about TB champions. And I want to confirm that Homa Bay experience, we are working very closely with our TB champions. We have a network, a very strong network of TB champions, and they have their chair, who I think is in the call. So we have a schedule of meetings, actually sometimes quarterly, sometimes biannually, where we discuss all these measures of TB prevention, treatment and adherence support. So we discuss TB preventive therapy with our champions, and during their community engagements, when they get fora, there's some of the information they give to the people. Because initially we could see instances where the caregivers were asking why the contacts are being given TPT. So we use the champions to give this information to the community, to the caregivers, and we've seen their contribution in improving TB preventive therapy uptake in Homa Bay County. I don't experience for the other counties, but I know they have a national network where Steve Anguva is part of it. So they usually share their reports on a monthly basis. So yes, we are engaging the TB champions in our counties.
Thank you very much. I think we need to strengthen TPT uptake, especially among contacts of people who have been treated for TB, and also for people who are high risk, like healthcare workers and people who have HIV positive tests, and also people who have other conditions like that make their immunity go down, like diabetes, cancer, and other related conditions that reduce the immunity of the people. We have another question requesting you to explain further about what Kenya is doing in regards to ensuring that there is diagnostic tools at near point of care, at the nearest point of care, and also if you can talk about the chest X-ray with AI, the distribution and usage in the counties. How is it? How many do we have currently in the country, and how many are functional? I think that question may not be answered by Mr. Karoli. I think the objective of this meeting today, this webinar, is to create awareness about TB and to be able to empower the attendees of the webinar to be able to participate in TB prevention and control. So I think the very technical questions about the distribution of the and usage of at the county levels, I think that is a question that can be answered in a separate webinar. But today, the aim is to actually create awareness among the participants and to be able to improve uptake of TB care and services by the public, and also to drive community and empower TB. So, Mr. Karoli, if you could just talk about.
Yes, Jessica, you are breaking, but we got you. What I want to say is that the country has really improved access to TB diagnosis. As I said, GeneXpert technology was introduced around the year 2010, but the National TB Program has actually supported nearly all counties. At least every county has access to GeneXpert testing. So what we are doing is that where we have the GeneXpert equipment, all presumptive cases will be tested at that facility. But where we receive patients in the peripheral sites, we don't refer patients to travel physically to the GeneXpert site. What we do is that we have strengthened our sample networking mechanism. So we collect sample and take to the nearby GeneXpert site. So we have really improved access to TB diagnosis through the molecular equipment that we have, GeneXpert and TrueNat. For chest X-ray, this has been rolled out sometimes late last year through various collaborators, the Global Fund, the CDC, and as we speak, I'm sure every county has got one or two digital chest X-rays. So we have these X-rays that help us in screening, digital X-rays fitted with artificial intelligence. So they can be used at the facilities where they are installed, or we can also carry them to the field during outreaches and really use them for TB screening, and the outcomes are very, very encouraging. Thank you.
Thank you very much. There is a question by Mr. Peter Owiti. We want to end TB, but our X-ray with card is lying idle because of the Kenyan Nuclear Radiological Authority had to approve installation. Why the delay? I think this is an agenda that can be answered by the program, but not in this forum. And as I earlier said, that we are trying to create awareness about uptake of TB services in this session, because we also have people who are beyond healthcare settings. We have people from learning institutions, we have community leaders and such. So we are going to address that. And you can directly message me, probably Peter, so that I can be able to address you directly, or which county that you're talking from. We have nutritional support for patients is out of stock, and what's the national plan and the TB program for the same. There's a question also by Peter. TB is infectious disease, so how do we integrate with an airborne disease? What is the progress in the near point of care diagnosis, and when is when we are transporting sputum? I think these are very technical questions. In this forum, we have people who are not technical, and I think we are not going to answer some of those questions in this forum. But ideally, what I would like to tell you is that the theme for this year's World TB Day is that it is led by government and powered by the people. And I think from today's webinar, we encourage you as TB champions and TB advocates to actually voice some of these things at the various counties where you are. And you are empowered today, and you can be agencies for TB. You can be advocates and champions for TB to be able to drive the agenda at the county level and at the facility where what is nearest to you. And also, since you've been made aware today for the interventions, I think you can be able to intervene at the county level or advocate at the mainly advocate at the county level. There is a question about integration. The TB is infectious disease, so how do we integrate with an airborne disease? How do we integrate with an airborne disease? Maybe Mr. Karoli, you can share your experience, which we look into screening and also prevention of IPC in healthcare facilities and also in other health services where we provide care. I think that would be helpful so that you create awareness about the need for screening earliest as possible in the facilities and IPC measures at the facilities. Welcome.
Thank you, Dorcas. As you rightfully said, there are several models of integration. It is not a one-fit-all for all facilities, but the emphasis should be infection prevention and control even as we integrate. So there are several models of integration. Thank you.
Thank you very much. I think to strengthen, to add to what Mr. Karoli has said, in the healthcare facilities and also in some of you are from training institutions, learning institutions and community settings, we need to ensure that where people congregate, we need to identify people who have symptoms for TB. And I think he mentioned cough and maybe other symptoms. Maybe Mr. Karoli can go over it again. And to ensure that there is aeration in every place, we are crowded, and also that wherever we are sitting, management of sputum, for example, and coughing, cough etiquette in public places, but the integration in the health facilities actually is determined at the point of care or at the healthcare facility where we have provided technical support to strengthen IPC. And I think in this webinar, we can talk about community prevention so that people are not crowded. We have community leaders in this webinar. We advise that when you have community setting meetings, so people do not crowd together. Maybe one person has TB, it can easily spread, so you need to ensure that there is an aerated, we sit in aerated places, not in one cramped room, or even in public meetings, they can sit outside, or if there's somebody with a cough or any of the symptoms, you can be able to pull that person aside and maybe advise that they seek care before they can sit in an enclosed place with other people in public meetings. And I think the main thing we are driving today is that the communities need to identify TB as a serious disease, and that TB can be prevented at the community level through awareness. We are aware what TB is, what are the symptoms are, what action we need to take, and so that when we see anybody with some symptoms, we can refer them to the facility for care. And when they have been diagnosed to have TB, then what type of TB, so that we know how long they'll be on treatment. We can be able to support them, encourage them, and also remind them to go for care that they need to go through. For example, the follow-up for the sputum, and also support them and encourage them, give them moral support and care, and understand them that it's a very difficult disease, but it takes also long to treat, but it's curable and preventable. So I think we are not going to talk about the health facility structure in this webinar. I think that will be discussed when we have healthcare workers and when we are providing technical support.
Sorry, Dorcas, there was some questions to the beginning. So there was the first one of delay of culture is a major setback. And then there was another one in a scenario, a child is born to a HIV mother who is also on anti-TB at intensive phase. Is BCG vaccine administered to the baby or withheld first?
Okay, Mr. Karoli, could you please answer the question?
Thank you, Christine. Delay of culture, I think, is being addressed at the national because we had some labs, but I think it is being addressed. So we've been sending culture samples to either Kisian, like in Western Kenya, we send cultures to Kisian. I think that an issue sometimes late last year, which is being addressed. And I think when it is sorted, then the turnaround time will improve. Meanwhile, what we are doing currently, we have rapid tests that we can use to do DST for our drugs. We have the 10 color-coded gene expert, which is being distributed to the regional centers of excellence. So this will be a stopgap measure where we can do our drug susceptibility testing as we also address the culture functionality. For a child who has been born to HIV positive mother, I think the most important thing here to the child to be assessed at the facility and the clinician will make a decision. And the most here is to find out whether the child already has got active disease. Then we'll put them on treatment. If they are not, then we'll start with the TPT, and then we delay BCG until we complete TPT. 2 weeks after TPT, then we can introduce BCG. So just refer the child to the nearest facility. They'll be assessed, and the action will depend on the evaluation of the child at the facility. Thank you.
Thank you very much. There's also a question: can a malnourished TB patient truly complete 6 months of treatment without food support?
We really want to give holistic care to our patients. I know we've had challenges with our nutritional supplements, but what we're doing is nutrition counseling. There are also other forms of support we are giving, including vitamin A, vitamin B6, and also counseling our patients. In a few other areas, I think we have got small support from other partners, but where we do not have the supplements, we continue to do nutritional counseling and involving our nutritionists in our facilities. So yes, I know malnutrition is an issue, but we offer counseling, but where we have supplements, we provide, and we continue to address that. And I think the program lead is actually giving guidance that we really need to emphasize on nutritional counseling. Thank you.
Thank you very much. I see somebody pointing me to a question on lenacapavir from people.
There are several questions on the chat side.
Ooh.
That one for lenacapavir is there also on the chat side.
Maybe the person who asked, could you please just unmute the person and speak?
So I can't know them, but there is a Tumba who has asked, can a malnourished TB patient truly complete 6 months of treatment without food support? I think that one you have answered. Where are we in terms of data?
I see
because this is what informs the program. You have seen those questions.
I see a question on lenacapavir. Can patients on lenacapavir vaccine, can TB patients receive this vaccine?
Yeah, lenacapavir is actually a preventive intervention for HIV prevention. It is a new molecule that is being rolled out, and I think there are eligibility, these criteria for lenacapavir, depending on the risk of the patient. And as we continue, we'll be giving more information to our people about lenacapavir.
Somebody who also asked a question that we stopped using masks after COVID. What are you saying about that?
Yeah, so in our infection prevention and control program, we have several components. We have administrative component, we have environmental component, and finally, what we call personal protection, where we train people about use of mask. We have N95 and face mask. So these are things that we train our healthcare workers and our people when to use the face mask and when to use the N95. N95 is usually used by the healthcare worker, and the face mask is put on by our clients as they come. So it depends on the risk at the time of engagement. So we'll advise our patients accordingly if they're available and how to use it properly. So that is a training program that we usually give health talk in our facilities to healthcare workers and even to our patients.
Thank you very much. There is also another question. We are facing lower TB funding in the communities to save lives from TB disease. What are the measures to assist in these areas? And also, given that TB is a global disease that affects even people coming from outside Kenya. Can you make a comment there?
Can you come up again, Dorcas? I missed that.
That we are facing lower TB funds in the communities to save lives from TB disease, and what are the measures to assist in these areas?
Yeah, so we are continuing in the advocacy, and I really want to appreciate what our partners, the SRs, are really doing in supporting counties to do what we call domestic resource mobilization. And this is one of the agenda we are pushing at the county level and doing advocacy so that we can have more domestic resource mobilization from the counties, from our budget, so that we supplement what the government, national government is providing, and even our partners. So it is a discussion, and especially now when we are doing what we call transition, we are doing a lot of advocacy with our stakeholders to ensure that TB funding is really improved at the county level. So that is the current position, and we hope we will get adequate resources to continue implementing our strategies.
Thank you, Mr. Paroli. In addition, I think creating awareness, in fact, during this pre-World TB Day, giving you information so that you are agencies of the TB program, your agencies of self-agencies at the county, and also that health is devolved to the county level. You should be able to participate when you hear there is a public meeting or forum to develop or adopt the county work plan, the budget. I think you need to participate there to ensure that there is funding allocated for TB at the county level, not just TB treatment, but also creation of awareness and prevention, early screening and early diagnosis, and also management and support, and allocation of also funds for nutrition supplements. I think you need to also be agents powered by communities. It is led by the government, but it's powered by the community. So powered by communities is your active role in participation in setting agenda, setting priorities, and participating in awareness creation on TB. There is a very important question here, and it says, what are the measures of global support for mitigation of TB disease? What are the measures of global support for mitigation of TB? But by fund support, enough TB screening tools, as well as deployment of TB specialists for future TB-free zones. What are the steps forward to support TB champions and to hardly work on TB clients in the communities? And what are the measures to provide TB champions with insurance cover due to risk handling TB patients? Wow, that's a very long question, very important points. I don't know if you received all of them, Mr. Karoli.
Yeah, let me comment on the level of engagement with our TB champions. And I want to confirm that from Homa Bay, we have really worked very closely with our TB champions. supported by our SRs. So what we do is that all our TB champions have been supported to undergo the basic training on their roles as champions. And then we give them basic information on TB prevention. So we are really empowering them in terms of knowledge so that they know as they engage in the community or the household, they know the basic preventive measures for TB. So they say knowledge is power, and that is what we are giving our TB champions. At the global level, I may not comment, maybe that is a national undertaking, but you know the donor environment is changing very fast. And I think you know the developments that are taking place, and we hope will continue to sustain the gains that we have made in TB control. Thank you, Dorcas.
Thank you very much. At the global level, we have global targets that have been set for all countries, and Kenya participates in the setting of the global target. We have global development of guidelines, we have global development of treatment regimes and improvement of treatment products, and also innovations that help in the diagnosis and management of TB, and including the utilization of digital chest X-ray with AI, molecular testing, and improved regimens for TB treatment. So there is a lot of work being done and to improve care and treatment, and also the vaccination to ensure that all children are vaccinated. So these are some of the global interventions. They are standardized across the world, and at the country level, we adopt them and implement them, and we roll them down to the counties and also to the community so that they can be able to participate. We are all participants and stakeholders in TB care, from the global level to the community level and to the individual or self. Every one of us is a TB advocate and a participant in the prevention and control of TB. There is a question that asks that where are we in terms of data, because this is what informs programs, budgets, and policies. I think that is indeed we collect data at the TB program, and we collect different kinds of data. We have routine data that we collect for TB care, for the care cascade in creation of awareness, screening of patients, diagnosis of patients, and treatment of patients, and also follow-up of patients and investigations. And we also collect data, supplementary data that support us in policy making. We do this through